our speaker today, Dr. Tonya Webb at University of Maryland. And so she does exciting work on health disparities and cancer. And when I met her like a year ago, probably, I told her we said we'd work together someday. We're still trying, but it will be a good opportunity for us to hear what she does and how we can collaborate in future. So thank you, Dr. Tonya Webb, for coming today.
Oh, thank you so much for having me. I really appreciate the opportunity to share our work. I will talk about some of our science, but also more along the lines of how I got into the field. And so the goal of the research in my lab is to induce killing of cancer cells by immune cells. And so I thought this was a nice little schematic. And these are my disclosures. I won't talk about any of this work, but I never thought that I would work with companies. So my statement for this is to dream big and never stop pushing. It's really nice to see how what you do in the lab can be translated. So along the lines of me growing up, I'm originally from Charlotte, North Carolina, and this is my family. I'm here, and this is my brother and my sister and my parents. And everyone has their own journey or struggle. So for me, early on, it was going to many different schools. So I put down as many as I could remember here, from elementary to middle school or junior high, and then high school. And so again, everybody has their own journey, and it makes you who you are, right? So it helps. So for me, going to all of those different schools helped me to be able to learn how to communicate effectively, stand up for myself, and push forward. And then for the students out there, this is my brother and his son. So it doesn't matter what stage you're in. Always remember that there's someone looking and that you are a mentor and can be an inspiration to someone. So again, my talk is focused on the journey. And so I just want to highlight that if I would have seen this quote a long time ago, it probably would have helped me out, that there's a journey that's waiting for you. You will make great discoveries. You will find treasures and hidden power. And it's a journey divinely designed just for you. So I saw this quote and was like, oh, this is so nice. I wish, again, that I would have seen this, but it is about the journey. So when I was in high school, my father passed away, and a lot of things changed for me in regards to going to college. But I was fortunate enough to receive a full scholarship to Prairie View A&M University. And they had an amazing biology program, pre-med program. And I was able to get my tuition completely covered and have an amazing experience. And while I was there, my junior year, we were having a career fair, and I was pre-med. I really thought I was going to go to medical school, but a recruiter came, and actually he became the department chair of microbiology and immunology at Dartmouth College. And he said that he thought that I would be great at research. And I thought, I'm not sure why you think that, but again, you have to take advantage of opportunities. So I went to Dartmouth. It was very cold. It was very far away. But I had an amazing research experience, and it completely changed my career trajectory. And I decided that I wanted to go into research. And then I did another internship at Indiana University, Purdue University in Indianapolis. And I really had a great time conducting research. And so I decided to go there for my doctoral studies. And I stayed there for a postdoc. And then I decided to come back to the East Coast. And I did a second postdoc at Johns Hopkins. And while I was at Hopkins, I was fortunate enough to receive a K award, a 5-year K award. And then I began my research lab at the University of Maryland School of Medicine in 2009. And of course, I wouldn't be where I am if I didn't have an amazing team and really fantastic people in the lab. So these are some pictures of my lab over the years, and I wanted to highlight, this is my lab in 2024 when I had 2014, excuse me, when I had my first graduate student defend. And she had never been to an amusement park in the US. So my entire lab went to Six Flags, so you can have fun. And I also want to highlight Courtney Culpepper. So she graduated from Morgan and she went on to have a fantastic career. So she's an amazing scientist. I met her a few years ago at the AAI meeting, the American Association of Immunologists meeting, when she was transitioning from her graduate studies to her postdoctoral studies. And again, it's a really small knit community and you have amazing people throughout the way. Oh, go ahead, Christine. Oh, again, so I just again want to give a shout out to Courtney, who is an amazing, phenomenal scientist. Also, I want to reiterate that family and friends are important. So you're maybe in the lab working really hard, conducting your studies in the classroom, and you may feel that it's all consuming. But remember, again, that friends and family are really, really important. So this is my immediate family. My oldest graduated last year and is now at UMBC. This is my brother and sister from the holidays this past December. This is my mom and my mother-in-law, and then my kids again with my niece. So that was a very short trip into my journey, but the work in my lab is focused on cancer immunotherapy, and it's been heralded as the breakthrough of the year multiple times. And of course, I'm excited about it because that's what I work on. And so if you look at this image of time here, it says, what if your immune system could be taught to kill cancer? And that's what we want. Again, we want to induce a potent anti-tumor immune response. So the same way that you get vaccinated for COVID and for the flu, and your immune cells come in and kill virally infected cells, that's what we want. We want to train your immune system to kill cancer. And this issue goes on to say inside the brutally selective, and that's because it only works in about 30% of patients, and it can be hugely expensive. So it can cost $30,000 to $50,000 per cycle per treatment, and you can need 5 cycles. So your take-home bill could be $1 million, which is very, very expensive. But if it saves your life, right, you can't put a price on that. But we want to address this, and we want to focus on the life-saving trials of immunotherapy. So the work in my lab is working to make this therapy broadly applicable and less expensive, again, so we can focus on the life-saving trials of immunotherapy. And I have to reiterate that science is a team effort. So this is my lab from a few years ago. And I will talk about our work on ovarian cancer that was largely done by Irina, a former graduate student in the lab, and Dominique, a former postdoc in the lab. And for those of you who like soccer, here's a nice quote from Pele. So success is no accident. Of course, you have to work hard and persevere. And you have to love what you're doing. And then these are just a couple of pictures to highlight some of the programs that we have. So we have a training grant for graduate students from underrepresented groups. And this is our UMB IMSD program. And these are some of the students that participated in the sweater contest. And then I have a summer program for undergraduates. And here's a QWERTY code. So if you have your phone, you can take a picture of it. If not, you can reach out to me and I can send you the link. The site is open until March 15th. I'll select 8 students from underrepresented groups to conduct research over the summer. And so the program was started in 2021. And this was our inaugural group where we had 4 students. And last year I was able to double the program to 8. And this year I've received funding for another 8 students. Okay, so back to the research. So my lab focuses on natural killer T cells, or NKT cells. And they have characteristics of the early innate immune response and the later adaptive immune response. So NKT cells can come in and quickly kill cancer cells as well as infected cells. And then they produce factors or cytokines that can help other members of your immune system, like classic T cells. And importantly, they recognize lipids. Instead of proteins, NKT cells are activated or suppressed by lipids. And when I talked about making our therapies broadly applicable, everyone has NKT cells. So everyone also has T cells, but T cells are very, very different among different individuals. But NKT cells have a conserved T cell receptor, and that's how they're activated. And so everyone on this call has NKT cells that have this semi-invariant receptor and has been conserved over evolution. So mouse NKT cells have a conserved T cell receptor that can recognize human CD1D proteins presenting lipids. So you can go across species. So that's how conserved NKT cells are, which you can't do for other immune cells. And we believe that they're a promising target for cancer immunotherapy because, as I mentioned before, they can directly kill tumor cells, and then they produce factors that aid your other immune cells. However, their potential has been limited because they are reduced in number and function in cancer patients. And so we want to figure out why are they reduced and restore their function so that we can use them as an immunotherapeutic strategy. And so how do we know that NKT cells are important? If we look at mice that are lacking NKT cells, so this is the J alpha 281, these mice don't have NKT cells. And if they are given a chemical carcinogen-induced tumor, MCA, so again, you can paint the skin of a mouse with carcinogen and the mice will develop tumors. And if the mice don't have NKT cells, the tumors develop much faster. So the open squares here are mice lacking NKT cells, and you see very quickly that tumors arise. So if you don't have NKT cells, you have an increased susceptibility to tumor formation. Not only that, again, the J alpha 281 knockout mice do not have NKT cells, but we found that if you give them back, if you give NKT cells to the mice, the tumors go away. So this is why, again, we're focused on NKT cells, because if you don't have them, you're more susceptible to developing tumors. And if we give them back, the tumors will shrink. So I told you that NKT cells can play a key role in getting rid of tumors. And if they are doing this, then, and your other immune cells are doing this, then why do people get cancer? And so this theory is called the 3 E's of cancer immune surveillance. The 3 E's are elimination, equilibrium, and escape. So in the first phase, in the elimination phase, it happens exactly as I mentioned, where your immune cells will come in, the gray cells here are your dead or dying cancer cells. And they're dead or dying because your immune cells can come in and attack. And so this is what normally happens. So it's thought to 1 to 3 times per day, you have cells that can become dysregulated. And if they don't stop and fix themselves, or senesce, like do not do anything, or are not repaired, they could go on to develop into cancer. So again, this is happening all the time. It could be happening right now. But again, they either can stop, repair themselves, or die, or your immune system can come in and get rid of it. And you never know there's a problem. So this is happening again all the time. But cancer cells want to grow. So they can decrease the proteins that your immune system is seeing and using to get rid of them. So if they lose these proteins or these antigens that your immune system is using to sense them, you can reach a state of equilibrium where the cancer is not completely cleared. And then eventually this cancer can escape immune pressures. So the tumor will recruit in regulatory cells and suppressor cells, as well as secrete inhibitory or suppressive factors. And so when you have all of this inhibition around this suppression of your immune system, then the tumor will escape these selective pressures and continue to grow. And this is what happens when someone comes in the clinic. When you actually present with cancer, when you have a mass, is when the tumor is in the escape phase. So we want to figure out what are these inhibitory factors, what are these suppressive factors, so that we can target them so that your immune system can come in and eliminate the tumor. And the cancer that we have been focused on is ovarian cancer. And the reason why we're focused on ovarian cancer is because it's the 5th most common malignancy affecting women in the US. And while more than 70% of patients initially respond to treatment, the majority develop recurrent chemotherapy-resistant disease. And this is because ovarian cancer symptoms are relatively mild. You can have nausea, back pain, weight gain, or weight loss. And it happens to women usually in their 50s to 60s. And so everyone experiences that, right? Weight gain, weight loss, nausea, back pain. It's, again, very mild symptoms. So when patients come into the clinic, it's usually at a late stage. And when you come in at a late stage, your 5-year survival rate is lower. And so if you come in with stage 3 disease, it's less than 25%. And for stage 4, it's only 5 to 10%. But we know that patients often present with this fluid, this accumulation of fluid in their abdominal cavity called ascites. And so when I was working on during my postdoctoral studies, I hypothesized that this liquid, this ascites, likely contain immunosuppressive factors. And that's why the fluid was accumulating and why the tumor was continuing to grow. So again, we thought that ovarian cancers were secreting inhibitory factors in this fluid that was suppressing the immune system. So to do this, we set up a pretty straightforward experiment. We collected this ascites fluid from women, treated our antigen-presenting cells, or these are the stimulator cells that can activate NKT cells. So we collected the fluid, used the fluid cell-free, treated stimulator cells for 4 hours and said, can these cells activate NKTs? And I'm showing you this because, of course, we found that it was the case where when we treated with ovarian cancer patient ascites, so on the x-axis, I'm showing you 3 different patients and a panel of NKT cell lines, and we found a 50 to 100% reduction in the ability of the stimulator cells to activate NKT cells after just a 4-hour exposure to ascites. So very, very rapidly, the ascites was able, exposure to ascites fluid completely suppressed the ability of these stimulator cells to activate NKT cells. So then you're wondering probably, what is it, right? So because NKT cells are activated by lipids, we reasoned that they could also be suppressed by lipids. So we extracted the polar lipid fraction from the ascites. And we used ascites that was moderately inhibitory. And we found that most of the suppressive activity was in the lipid fraction. And then we worked with Dr. Schnarr's group, Ron Schnarr at Hopkins, to run thin layer chromatography, or TLC. So can you believe this classic work that you probably did a long time ago? We still use it. So we ran TLC to figure out what lipids they were. And we found that the activity was in the ganglioside fraction. And if you had more of these gangliosides, you had a greater level of suppressive activity, or NKT cells were more suppressed. So this was great, right? We found this lipid. And so we wanted to figure out exactly which one it was. And so for time, I'm only showing you 2 here. So we purchased GD3 and GD2 from Avanti Polar Lipids. And then we treated our stimulator cells with increasing concentrations of GD3 or GD2. And we found that when we increased the concentration of GD3, we lost NKT cell activity. In contrast, with just 1 sugar less, GD2, there was no effect. So this is pretty exciting. We actually identified a suppressive factor that was present in patient samples. And so we wondered, did it have activity in vivo? So then we took C57 Black 6 mice, injected them with an NKT cell agonist, alpha-gal SER, and increasing concentrations of this suppressive lipid. And so when we inject alpha-gal sera, if you look at the pink line, we got nice activation of NKT cells. We could measure interferon gamma, cytokine in the serum. And so over time, we measured interferon gamma and again got a nice increase in vivo. However, when we added GD3, we saw a dose-dependent suppression of NKT cell function. So in vivo, this lipid suppresses NKT cell activity. And for those of you who like structure, here's the structure. So this was exciting. It could be like a needle in a haystack to actually find the inhibitory factor that's suppressing immune cell function in patients was really, really exciting. And so I was doing that work when I started my lab here. We finished some of the studies, and I had a very enterprising graduate student who said, okay, that's great, you found a lipid, but there's probably other things in there. And so then she started working on VEGF, or vascular endothelial growth factor. And that's because VEGF levels in patient ascites are much higher than what's found in other tumors. So compared to ovarian cancer, VEGF levels are extremely high when you look at that and compared to patients that have ascites with other types of cancers. Also, high VEGF levels correlate negatively with outcome. So if you have high levels of VEGF, your chances of survival are reduced. And VEGF levels correlate with invasion and metastasis. And VEGF has been shown to aid in the recruitment of suppressive immune cells like myeloid-derived suppressor cells. And so Irina decided to look at this. And so I'm showing you again just a couple patient samples for time, but we compared patients that had higher VEGF levels to lower VEGF levels. And when we looked at immune cells in the blood, when you had higher levels of VEGF, you had a reduction in NKT cells as well as other T cell subsets. Not only that, when we looked in ascites, which is where the tumor is, and in the blood, we saw that patients that had higher levels of VEGF had a reduction in function. And then she wondered, does that directly impact NKT cell activation? So she treated with increasing concentrations of VEGF and saw a loss of NKT cell function. And we use cell lines for this, as well as primary cells from mouse liver and human blood. And again, when you treat with VEGF, you lose T cell function, both in mouse cells and in human cells. So then she wondered, can we restore NKT cell function? So what if we block it? So she used two different ways: an antibody, Avastin, and this is what's used to treat patients, and it's been shown to dry up ascites in ovarian cancer patients. So it reduces that fluid. It doesn't serve as a cure if you only give Avastin, but it does cause a reduction in ascites fluid. And then we also use genistein, which is a tyrosine kinase inhibitor. It's a drug that's been shown to reduce VEGF in ovarian cancer. So again, the question is, if we block VEGF, do we now get NKT cell responses? And yes, so we treated ovarian cancer cell lines with Avastin or genistein, and then took the culture supernatant and treated our stimulator cells. And if we block VEGF for 3 days, we restore NKT cell function. So this is great. So we found GD3 and we found VEGF. So then Irina wondered, is there a link between VEGF and GD3? So what she did was she treated 2 human ovarian cancer cell lines with genistein to block VEGF, and then look to see if there was a difference in GD3. So the black dark line here is the control, and the hatched is after treatment with genistein. And so if you see a leftward shift, that's a reduction. So she found that if she blocked VEGF, we also got a reduction in GD3, which was pretty exciting, because it was the first time someone had made a link between these two suppressive factors and showed that something that's important for developing a blood supply, for the cancer to develop a blood supply, such as VEGF, was linked to this suppressive lipid shedding. So then you may be wondering, where do we go from here? Of course, we wanted a treatment. So we tried so many different things. We tried omega-3 fatty acids. We tried HDAC inhibitors, a histone deacetylase inhibitors, many different drugs. We tried to block the VEGF GD3 axis. And this led us to triptolide, which is the active ingredient in a Chinese herbal medicine that's from the thunder god vine. And it's been shown to be a promising anti-tumor agent in many different cancer models. It's been shown to inhibit angiogenesis, and it's also been shown to downregulate GD3 synthase, which is the enzyme needed to make GD3. So this work was done by a postdoc in the lab, Dominique, where she treated the 2 ovarian cancer cell lines with triptolide for 24-48 hours and saw a reduction in VEGF, a reduction in VEGF receptor 2, and a reduction in this enzyme, GD3 synthase, that's needed for GD3 to be made. So this was exciting, right? And not only that, she found if she treated the ovarian cancer cell lines with this drug, now these cells could be killed by NKT cells. So at the top, we're looking at interferon gamma. This is a protein that helps stimulate the immune response. And as we treat with triptolide, we now get an increase in interferon gamma, which is important for anti-tumor responses. And below, if you look at C and D in 2 different healthy donor cells using their blood, we were able to show that treatment with triptolide results in sensitizing the ovarian cancer cells to killing by NKT cells. So this is very promising. So then again, you have to keep going. So what happens in vivo, right? We found these 2 targets. We found a drug that works in vitro. So now what happens in vivo? So to do this, we had to develop mouse models of ovarian cancer. We used a metastasis model, ID8, and a VEGF line, overexpressing line called ID8 VEGF. And what happens is you inject the mice with this ovarian cancer line and it metastasizes similarly to what's found in humans, and the mice develop ascites. And we used a spontaneous mouse model where the mice have this SV40 large T antigen under the control of the ovarian glycoprotein promoter. And so you get transformation in the fallopian tube starting at 6 weeks. And then by 12 to 13 weeks, the mice have tumors that are so large that the mice have to be euthanized. So we characterized the mice and made sure that in these cells, we saw the same thing that we saw in our human sample. So we looked for VEGF and it was present. We looked for GD3 and it was present. Remember, NKT cells are activated by lipids presented by CD1D. We found that the ovarian cancer cells did express CD1 and it was functional. In addition, as you could assume, because the tumors are secreting VEGF and GD3, they are suppressive. And then, so that was in vitro characterization. In vivo, we found the same thing. So we injected C57 Black 6 with the ovarian cancer cell lines and measured abdominal circumference, saw that the VEGF overexpressing line grew faster as expected. We could detect VEGF in the ascites of the mice. We looked for NKT cells, and surprisingly, we found higher percentages of NKT cells in the mice that had the ID8 VEGF overexpressing tumor. And we looked at we quantitated the amount of lymphocytes there. We did find NKTs and total T cells. However, when we looked at their function was reduced. We also characterized a spontaneous model. I told you that after 12 to 13 weeks, the tumors are very large. And here you can see it's a huge tumor. And when we looked in the uterine fluid, there are very high levels of VEGF. We found suppressive cells in the fluid. And when we activated the cells outside of the mice, we found that their immune cells, their T cells could be activated. So we treated the mice with triptylide or an NKT cell agonist, but we were not able to recapitulate our in vitro studies. So before I showed you that the drug treatment was effective, but when we looked in mice, we did not see that. Initially, the tumors decreased, but then over time, the tumors grew back. And we found that was because the ovarian cancer tumor microenvironment is highly immunosuppressive. So if at first you don't succeed, try again. So now I'll tell you about ways that we are trying. So we were wondering again, what reduces the efficacy of our immunotherapeutic approaches? And so in a collaboration with a group here with Doctors Reeder and Roque, we started to analyze microtentacle phenotypes in ovarian cancers. So microtentacles are these projections that help ovarian cancers metastasize. And this is how they're able to disseminate throughout the body. And they can have different configurations of these microtentacles. So we took a panel of ovarian cancer cell lines and characterize these projections. And what I really want you to notice here is that when we take the ovarian cancer cells initially from patients, you see that they have these large projections, but after just passaging them 2 times in the lab, they completely change their architecture. So this tells us that we need to develop better models to more closely recapitulate what's happening in vivo. And so that's what we are working on now. How do we develop better model systems so that what we find in vitro can move forward? And so I just really quickly want to give a summary that we've been focusing on NKT cells and responses to ovarian cancer. And we found that ovarian cancers secrete inhibitory factors such as VEGF and GD3 that block the ability of NKT cells to become activated and kill the tumor, as well as activate other immune cells. And so to move forward, I had a post back in the lab, and Zodi, who worked to develop 3D models of ovarian cancer. So we don't have to go from our cell lines into mice. Now we can make multicellular 3D models and test our systems that way. And also I had 2 really great high school students that worked on developing diagnostics using nanoparticles for both ovarian cancer and breast cancer. So no matter what your stage is, you can do amazing science and be highly productive. And so what are we doing exactly? We want to develop a lateral flow assay or like a dipstick test for GD3. We're also using tissue microarrays to see if there's a correlation between GD3 and VEGF and outcomes in ovarian cancer. We're working on therapeutics. So as I mentioned, we've developed multicellular 3D cultures that we can add in immune cells and drugs and test efficacy before moving into mice. We've developed a high throughput drug screen so we can find drugs that are similar to triptylide that may be effective in vivo. We're also working on a GD3 CAR NKT. So for this, we take GD3 that we found that's being secreted, right? And then we'll use an antibody moiety that's targeting that and incorporate that into a lentiviral vector and make all of our NKT cells target GD3 so that the NKT cells can go directly to the tumor microenvironment and kill the ovarian cancer. And we're also interested in precision medicine, and we're interested in health disparities. So I'm doing some work in collaboration with Dr. Jones, Lisa Jones, to use proteomic approaches to examine disparity. So before we were working on SNPs, and now we've moved into this new area with proteomics, which is pretty exciting. And Dr. Jones has developed this fast photochemical oxidation of proteins technique where we can treat cancer cells with the drug, perform labeling of these treated cells, and it tells us which proteins are modified after the drug treatment. And then we can use mass spec to identify these changes. And so what we're doing is taking cells from, and for the proof of principle, we use triple negative breast cancer cells. And so what we're doing is taking cells from that are derived from African Americans and European Americans and treating them with similar drugs and looking to see which proteins are differentially modified after treatment. And so we've done this with cell lines as well as with primary cells from breast and ovarian cancer patients. And we found that the same drug works differently or modifies proteins differently in African Americans compared to European Americans. And a lot of these proteins have to do with metabolism, which is really, really interesting. And so we're working on this and we're looking to move forward. So I know I went really deep into the science. And so if you didn't get all of it, it's okay. This is a nice quote from Maya Angelou. It says, "I've learned that people will forget what you said, they will forget what you did, but they will never forget how you made them feel." So this is the recent picture from my lab. Remember your purpose. Okay, and so I would like to thank my lab members. I would like to thank all the patients that generously donated their specimens, and to all of the interns and collaborators that collaborated with us that help support our research, because of course we couldn't do it without them, as well as we needed funding. So grant support has been a great help. And again, this is a shout out for my summer program. So if you have your phones, you can get the link and please apply for the summer program. Okay, so I'd be happy to take any questions that you may have.
Thank you. Thank you so much, Tonya. This was fascinating. And I love that you started with where you came from. So that I enjoyed that a lot. And so we have some questions in the chat. Nicole, do you want to just unmute and ask them, or?
Oh, so I'm driving right now, so I can't really look. Right
Okay,
now.
so I'll ask for you. So the
Thank
first
you so
question
much.
from Nicole is, I want to clarify that the escape method of cancer survival is the recruitment of the stromal cells that inhibits the natural killer cells. Is ascites resulting from cancer or stromal cells?
Okay. So actually it's not the stromal cells, it is the ovarian cancer cells. So we were able to take ovarian cancer cells from patients, generate lines, and then show that those ovarian cancer cells are secreting the inhibitory factors. And another group showed that the ovarian cancer cells are actually secreting the GD3 into exosomes, and that's how it's suppressing T cell function and NKT cell function.
And then the other one was regarding the antigen presenting cells, macrophages and dendritic cells. Did you find differences in cancer stages or aggression with the absolute monocyte ranges?
Also, that's a great question. And we did not look at that in our ovarian cancer patient samples, but we have in our breast cancer patients and in our lymphoma patients. So it depends on the monocyte population. And when we looked at dendritic cells, we found that depending on the patient's pretreatment regimen or their disease stage or grade, their dendritic cells did not always function similar to healthy donors. And so we made an artificial antigen presenting cell so that we don't have to use the natural antigen presenting cells to stimulate our T cells and NKT cells. So we haven't really characterized them in detail in our ovarian cancer patient cohort, but we have in other cancer types, and we've found that they can be highly variable. We haven't made any direct correlations based on stage or grade. We've just looked at healthy donors and cancer patients. So in our lymphoma study, we had 50 lymphoma patients. In our breast cancer study, we had 34 breast cancer patients, and we compared those to healthy donors of similar age and sex.
Thank you. And then the final question from Nicole was, can you comment on your thoughts on the current association between natural hair relaxers and reproductive cancers?
So that is a great point. And there is a current case lawsuit going on about hair relaxers and reproductive cancers. So I feel I can't really speak on that. We haven't done anything with that. But we do know that carcinogens and can damage cells, and damaged cells, if they don't repair themselves, that can lead to cancer. And so again, I can't really speak. I have a lot of personal opinions about this, but scientifically, we haven't worked in the area. So everything that I'm saying is just my personal opinion on this.
And then could you address any connection to FSH and estrogen in the NK immunity?
So we haven't done anything on that. We collaborate. There's another Dr. Jones here, Londetta Jones, who used to work on environmental estrogens and breast cancer, particularly triple negative breast cancers. And we had some interest in this, but we haven't pursued it. So again, I can't really speak on that, but thank you for bringing it up.
And then add a question about, do you think, how do you think the NKT immunotherapy, like in future, will differ from the T-cell immunotherapy that's currently approved? Like, do you think this might be better? And then also how, because with the current immunotherapy, it doesn't work well in solid tumors. And so will yours run into a similar problem?
So actually, of course, I should say I am biased. I work on NKT cells, so of course I think they're the latest and greatest. But if you compare interferon gamma responses, NKT cells work very quickly, and they constitutively have message for our mRNA for cytokines like interferon gamma. So as soon as they're activated, they can release cytokine. And one NKT cells can produce as much as 10 classic T cells. So I think that you won't need as many NKT cells to have the effect. And I mentioned early on that that total T cells are highly variable depending on individuals, and NKT cells are conserved. And so you can have a universal NKT cell. You can use allogeneic, or you can use NKT cells from a different donor. So we could take NKT cells from a healthy donor, expand those, and give them to a patient with cancer. So I think that it's going to work much better. There is a group in Texas at Baylor and MD Anderson who currently have clinical trials going using NKT cell-based therapy. And they've used it in kids with brain cancers, and it's been effective. The patients have responded or had stable disease in 6 patients so far. So it's very, very early, but the early data look very promising. And in Japan, there have been really nice studies looking at NKT cells, adoptively transferring them into patients with head and neck cancers and lung cancers. And when they compared patients that had functional NKT cells, in 10 cases, compared to standard therapy, patients that received NKT cells had an overall survival of 29 months compared to 4.6 months when patients received standard of care. So to go from 4.6 to 29 months when patients with lung cancer is really impressive. So I think that it holds great promise.
Interesting, thank you. And for the solid tumors, will you run into a similar problem where it's hard to reach the solid, like prostate and breast? Like
it's true, you have to get them in. Yes, you're right. So NKT cells, so there was a study early on in 99, there was a study published looking at NKT cells and prostate cancer. And I think that the problem was NKT cells needed to be able to get there and infiltrate the tumor. And so now we're working on the tumor microenvironment. So there was a question before about the stroma. And so we think that if we target the stroma and reduce immune suppression, now we'll be able to get NKT cells to infiltrate the tumor and get in deep enough where they're able to actually kill the tumor. And that's what we're using the 3D models for. So we're making the stroma So we'll have collagen and fibroblasts and tumor cells, and we make layers of these cells, and we can see how far NKT cells can infiltrate. And so we're working on ways to get NKT cells to be able to go deeper within the tumor to help mitigate those issues.
Thank you. Nicole, you have another question?
Yes, yes, I do. So going back to with the natural hair relaxers and everything, should now we start to look at including that into like history assessment? Have you used perm, or and if it is, then having separate groups versus like natural hair versus people that have been relaxed, so that you can like compare the differences in gene expression between those who have ovarian cancer versus who hasn't had it, or I mean even between having ovarian cancer between the two groups.
So
Like,
that's great. I think that you're making me think. I'm like, I need more time so I can write a protocol, right? I need to write an IRB for that, because we are recruiting in patients all the time, and we could do this, right? So you're right, much more work needs to be done, and we need to sound the alarm. If there is an association there, we need to push this, right? So early detection is key, education is key. And if we can move this forward, we should. And so I agree with you wholeheartedly that more work needs to be done. And we need, again, yes, to promote awareness and put it out there so that we can advocate for changes and, again, put this out in the community so that we have less people suffering from this horrible disease. So thank you, because I know about it and I haven't like really implemented any action towards it in my science, and that's what we need, right? We need to take action. So thank you.
thank you.
Any other questions?
I just wanted to say thank you for the presentation, for sharing your life journey. I always thought it was weird that I changed 14 schools to do just 12 years of school, 2 different countries, 5 different cities, but now I have a sister who's done the same. So thanks for sharing that. I'm not alone. And it was fascinating that you're talking about anti-VEGF, because I do mostly eye research, and for AMD, Avastin and all kinds of anti-VEGF injections are so common. And I knew that it was an anti-cancer, but just to see how, you know, you're using the different mechanisms, and it's just fascinating. So thank you for sharing that.
Oh, thank you so much.
Thanks. I really enjoyed hearing you present your science. It's been a really long time, because most of the time when we talk, it's about developing undergraduate students rather than science. So I really enjoyed that.
Oh, thanks. And you know how we are, the chance to present our science. I was like, yes. Thank you.
Yeah. And speaking of gene expression, I'm just going to piggyback on what Nicole started and a discussion Dr. Darmara and I had yesterday. So you said there are different phenotypes, and I always have that in my mind. When we're talking about a disease, we just put one label on it, but it could be like a spectrum of disease. When we say headache, not all headaches are migraine. Don't just call everything migraine. We don't even know what a migraine is, right? So, and you talked about the different phenotypes. And so the ovary, of course, has different kinds of cells. Does it matter what type of cell? And can we, you know, again, makes you think, it makes you get excited about all the different work can you do. Do you have any plans to continue looking into those phenotypes and where they're coming from? Where's the cell originating from? What are your plans on that?
So it's great. So we've looked at different subtypes of ovarian cancer, and we focused on high-grade serous because it's the most lethal, but we have looked at other types, and we haven't found a difference. We need to look more closely and carefully, but when we surveyed the first like over 100 patient samples, we just saw that an increase in GD3 correlated with an increase in immune suppression, and we didn't see a distinction between tumor type. But now that we have the tissue microarrays, we're going in and looking more closely to see where they are. And I have a new graduate student. And before we were just looking at like stage, grade, and protein expression, but he was now wanting to look at demographics, age, and putting that in with stage and grade, and like really looking at all, like doing a multivariate analysis to see what correlations we can really draw and see if there's something there. If we use a broad unbiased approach, what do we really see? And so now we're going back and reanalyzing all this data we've been collecting over time to see really, what's going on.
Stuff.
Yeah.
Yeah, so I hear you. It's like you see a divergence, all the different types and demographics, but at the end of the day, they all come back to one determinant of what the outcomes. Okay, perfect. Thank you so much.
Yeah, and then the final thing also, Dr. Pilwali, he's in the math department, so he's saying he has a mathematical model to be developed further on eugenesis. For 3D models, I expect to have more discussion for potential collaboration, so he might reach out to you.
Oh, that would be great.
Mhm.
Making a note now. Thank you, Dr. Lee.
Yeah. So I'd like to thank you again for presenting today, and hopefully we'll start more collaborations with different people, and we'll keep in touch. So thank you so much for sharing your science and your journey with us.
Oh, thank you. And you'll hear from me. Yes, we're
Okay.
gonna work together. Okay, thanks. Okay,
Thank you. Take care.
you too.
Bye, everyone.